All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound case series. Today, we're joined by Dr. Arslan and Dr. Ryan Stefanczyk, both from Detroit Medical Center. They will be presenting on the medial gastroc tear. Dr. Arslan is a native New Yorker. He graduated from the University of Buffalo Jacobs School of Medicine. He later completed his training in emergency medicine at Lincoln Medical Center in the Bronx, New York, and he is currently a sports medicine fellow at Detroit Medical Center. Dr. Stefanczyk attended medical school and completed residency in physical medicine and rehab at the Medical College of Wisconsin, and he is now also a sports medicine fellow at the Detroit Medical Center. I will turn over to you guys.
All right, great. Thank you for that introduction. We will jump right into our talk. So to start with our outline, today we'll be presenting our case. We'll be going over the regional scanning protocol for the posterior knee, giving some pertinent differential diagnoses. And throughout the talk, we'll be presenting the images from our patient ultrasound, and we'll be building the ultrasound report kind of along the way as we go. Instead of giving all the findings at the end, you're going to see some white boxes with black text in them that are correlating to either the images or the videos on screen. And that's going to kind of be the exact verbiage that we're putting into our final report. So we're kind of build it along the way. So keep an eye out for that. We also wanted to give a quick acknowledgement to the writers of the MSK Room textbook, which is an excellent resource that we've used in building this report and just learning musculoskeletal ultrasound in general. So we wanted to acknowledge the excellent work that they've done helping us along the way. So we'll jump into our case. Our patient was a 60-year-old male with a history of GERD who presented with acute left calf pain. Our patient was able to get into clinic about 3 hours after his injury, which had occurred while he was doing some training. He was training for a Tough Mudder, doing high knees on a 45-degree incline when he felt a pop and an episode of sharp pain along his medial calf. He denied any previous injury to that leg, didn't have any paresthesias or temperature variations, and his symptoms were exacerbated by prolonged walking and prolonged standing. On physical exam, inspection of the left knee and calf was normal. With palpation, he did have some point tenderness over the left medial gastroc at the level of the myotendinous juncture. No tenderness over the patellofemoral joint, the medial knee, patellar or quadriceps tendons. And he had relatively normal knee range of motion with active plantar flexion. He had 5 out of 5 strength with quadriceps and hamstring muscle testing and did have 4 out of 5 weakness with plantar flexion. Our provocative testing was all negative, including negative McMurray's and negative Thompson's tests. Patient was neurovascularly intact, but did ambulate with an antalgic gait. We obtained plain film radiographs, and these were AP and lateral images of the left tib fib and left knee. These were normal without any fracture, dislocation, or soft tissue changes. So at this point, our differential was relatively broad, including a leaking or ruptured Baker cyst, DVT, pathology to the semimembranosus, medial meniscus, medial gastroc, plantaris tendon, or tibial stress fracture. So this is the time we got the ultrasound out and started our protocol.
Great, thank you, Ryan. So per the AMSSM posterior knee protocol, which we felt was most appropriate for this patient, this is the criteria that we wanted to include. So we started with the popliteal fossa and tried to evaluate the popliteal arteries and veins, looked at the semimembranosus tendons and muscles, an evaluation of the medial and lateral gastrocnemius muscles, tendons and bursae visible, the sciatic, tibial, and common fibular nerves, the posterior horns of both menisci as indicated, and the tibiofemoral joints, and the PCL as indicated. We came up with this nice little mnemonic, LMNOP. We thought it'd be good and pertinent to kind of try to remember the big structures we wanted to hit. You guys can take a look at this yourselves, but L is for ligamentous, M is musculotendinous, N is neurovascular, O is osteochondral, and P is for all the additional stuff that we put as plus. This slide kind of leads into the insertions, the origins, and the big structures in the posterior knee. And can be a little complex. So just to be aware and cognizant these structures are here, worthy of an evaluation to tease out on the ultrasound, and to kind of make sure that you capture this when doing your evaluation. So starting with the popliteal fossa, we would put our transducer in the midline of the posterior knee, and we're going to capture the lateral condyles, the intertrochanteric notch, and the medial condyle over here, overlying which we begin to see the neurovascular bundle. So this anechoic structure in the middle of the screen is the popliteal vein. The hyperechoic structure just superior to that, or superficial to that, that's the tibial nerve, as it just bifurcated from the more proximal sciatic nerve, and a little bit obscured here, but you could begin to see teased out as the popliteal artery. This is a good demonstration of what the transducer position overlying this area should show, which structures are over here. So the read here would say that the transverse view of the posterior knee shows intact neurovascular bundle, normal blood flow appreciated with Doppler, and the popliteal veins are fully compressible with no evidence of DVT. This is ideally where we would show if a DVT were present, we look for it here. We would apply pressure to collapse the popliteal vein, trying to avoid collapsing the popliteal artery. We also put it in long axis relative to the vessels, and we'd apply color flow to assess for flow within the lumen of the vessels. This is a nice little GIF image from the Cleveland Emergency Medicine blog that shows what a DVT would look like inside the vein. We could see a hyperechoic structure, and with the color flow overlying the area, we could see a lack of blood flow through the lumen of the popliteal vein. This is a nice slide that demonstrates that there are other types of blood vessels, other veins in this region. This is specifically demonstrating that a DVT could be present in a nutrient vessel to the gastrocnemius, a gastrocnemius vein. So not to just kind of anchor your diagnosis on a popliteal vein, to be aware that there's other things that could have a similar etiology. So now we're going to take that transducer and we're going to move it more medially. As we move it more medially, we're beginning to see a more full medial condyle. We're going to kind of round, almost as if this is an apex, we're going to put the transducer over here. This is showing the different muscles in this medial compartment over here. This is the medial head of the gastrocnemius and the semimembranosus muscle as it begins to transition into the tendons. So we see that medial gastrocnemius over here. We see actually the muscle belly of the semimembranosus, and this is some of the pes anserinine tendons, which are kind of difficult to delineate in a static image, but with more dynamic ultrasonography, we can determine if this is the semitendinosus or the gracilis. And this image over here kind of orients us to how our patient is, which is prone with the patella downwards, the condyles towards the ceiling. This is the left lower extremity. So this is the dynamic scan of our patient. We begin to move towards and see really the medial condyle more fully. We see the medial head of the gastroc muscle belly. We begin to see this hyperechoic structure, which is the tendon of the semimembranosus as it transitions from the muscle into the tendon. So I'm going to play that one more time. We'll see that this hyperechoic structure is the tendon of the semimembranosus, and as we move more proximally, it becomes more of the muscle belly. In between where these two muscles abut is where we'd evaluate for a popliteal or a Baker's cyst. So no evidence of a Baker's cyst, semimembranosus tendon and muscles are intact, no defects. This is just demonstrating again where we would look for that differential. So the Baker's cyst, the popliteal cyst would reside between the medial head of the gastroc and the semimembranosus. This is a great slide because it demonstrates the non-parallel fibers of the medial gastroc's muscle and the semimembranosus tendons, and how that becomes relevant during our sonographic assessment is that this could be affected, our assessment could be affected by anisotropy. So be very cognizant of this when you're scanning for the Baker's cyst and evaluating the muscles and tendons in this specific region, that these non-parallel fibers, you're going to have to adjust your transducer to be able to fully evaluate them effectively. On ultrasound, this is what a Baker's cyst would look like. We could see the body over here, and the key feature is visualizing this neck. This neck is a direct communication with the joint space. If this neck is not visualized, you have to consider other differentials like an aneurysm, a ganglion cyst, a schwannoma. So to make the diagnosis of the Baker's cyst, this is pretty important to see.
Next, we'll start looking a little deeper into the neuroanatomy of the posterior thigh, starting with the sciatic nerve. This originates at L4 to S3 and descends down the posterior aspect of the thigh. When it reaches the apex of the popliteal fossa, it divides into the tibial and the common peroneal nerves. Common peroneal nerve courses along the lateral side of the popliteal fossa, deep to the biceps femoris until it passes around the head of the fibula. The tibial nerve passes down the center of the popliteal fossa, running below the tendinous arch of the soleus muscle, and then down the midline of the posterior calf in between the medial and lateral gastroc muscles. An ultrasonic evaluation of these structures begins with a short axis view of the posterior thigh, identifying the honeycomb appearance of the sciatic nerve, and moving the transducer inferiorly to identify the split at the apex of the popliteal fossa, where we can identify the tibial and the common perineal nerves. In this patient, we were able to visualize the sciatic, common perineal, and tibial nerves without any disruption or focal swelling. Next, we move the transducer in the long axis view medially to view the posterior horn of the medial meniscus if this is clinically indicated. So the medial meniscus is usually viewed as a hyperechoic triangle that's located between the medial femoral condyle and medial tibial plateau. It's important to scan across the width of the meniscus, looking for any echogenic changes or extrusion of the meniscus beyond the bony borders. We also want to look at the bony structures, looking at the contour of the tibial plateau and the hypoechoic articular cartilage of the femoral condyle, which we can see right here. This slide gives us an anatomical view of the transverse meniscus, and you can see its location in between the femur and the tibia with an MRI correlation and a more textbook ultrasonic view on the bottom right. We then move our transducer, continuing in the long axis, medially to try to identify the PCL if this is clinically indicated. The PCL originates on the anterolateral aspect of the medial femoral condyle and inserts along the posterior aspect of the tibial plateau. So these are the bony landmarks that you want to visualize when trying to identify this structure. And usually this is done near the midline of the popliteal fossa and involves some rotation of the transducer to achieve what we call a true orthogonal view. This usually requires about 20 to 30 degrees of rotation. And due to the course of the PCL, it can be difficult to visualize all of the fibers in one static ultrasonic image. We can see the fibers coming in here, but it's important to be aware that due to anisotropy, the PCL can appear abnormal even when it is normal. So it's important not to get fooled and think you have a PCL tear when we're simply looking at anisotropy due to the angulation of the PCL. It's nice to look at the thickness with a thickness of less than 1 centimeter being normal for our PCL. And in our patient, we were able to visualize the PCL in the sagittal oblique plane with normal continuity of the PCL fibers. You can see on this anatomical cross-section the angulation that the PCL takes, and that can kind of appreciate how it would be difficult to view all of those fibers without any anisotropy. And we have a little MRI and ultrasound correlates to take a look at. After visualizing the PCL, we continue the probe in a long axis view, moving laterally to identify the posterior horn of the lateral meniscus. This is very similar to our evaluation of the medial meniscus. We're looking for a hyperechoic triangle between the lateral femoral condyle and lateral tibial plateau, looking for any defect. And on our patient, we visualize both horns of the medial and lateral meniscus with no abnormalities visualized. We also didn't visualize any abnormalities with the bilateral tib-fib joint with normal contours and no evidence of synovitis. Given the deep positioning of the meniscus and the obscuring nature of bone on ultrasound, ultrasound evaluation may not be the optimal imaging modality for visualizing the meniscus, but it can be important and useful in identifying certain pathologies. This is a static image showing a meniscal extrusion. In this case, you can see the meniscus is pushed well beyond the borders of the normal location, well beyond the border of the femur and tibia. You can also see some hypoechoic changes throughout the middle of the meniscus with some bony abnormalities visualized here and here. You can also visualize some of the tears of the meniscus. This would be a horizontal meniscus tear visualized as a hypoechoic defect passing horizontally through the meniscus visualized right here.
And this slide demonstrates the gastrocnemius's contribution to the posterior knee. So just as Ryan had gone over in the previous slide, the evaluation of the meniscus over here, this hyperechoic triangular structure. Over here, we see the distal femur demonstrated as the lateral condyle, and over here, the proximal tibia. But just superficial and overlying that, we can really begin to see the lateral gastrocnemius. So we're going to proceed to the evaluation for our patient here. If we could recall from the history and physical, our patient's focal tenderness was at the myotendinous junction of the medial gastrocnemius, this transition point, the weak point that we traditionally see the majority of our tears. So this cross-section view, we see the anterior, the lateral, the deep posterior compartments, but they're not really germane to our evaluation today. So really, the superficial posterior compartment is what we thought was most important for our patient. This big muscle over here is the soleus muscle. Over here is the lateral gastrocnemius, and over here is the medial gastrocnemius. The majority of medial gastrocnemius is tears at the medial portion of the muscle. So when placing the transducer, it's really important to evaluate this interface between the soleus and the medial gastrocnemius. So this demonstrates an ideal area to place the transducer. And as we had just seen in the previous cross-section, that's where we're trying to place our probe. This shows from a textbook perspective what we're looking at. Again, an ideal transducer placement. This is what the ultrasound will show us. So if we're looking at the more deeper structures over here, this is the soleus muscle. As we move more superficially, we begin to see its respective aponeurosis. And between that is the intraaponeurotic space where we could begin to visualize the plantaris tendon, and we'll talk about that a little bit later on. Above that is the medial gastrocs aponeurosis, and then we also see these oblique fibers, these homogeneous continuous fibers of the medial gastroc. And over here is really just superficial soft tissue. So this is our patient's ultrasound of his medial gastroc, this dynamic scan. So what we can see here, let me actually just put this on loop because it's really important for our diagnosis. So as we had just demonstrated, this is the soleus muscle, its respective aponeurosis, the medial gastrocnemius. So we're looking for the homogeneity of the muscle fibers, but we don't see that. We see heterogeneity with anechoic and hypoechoic fluid. And we think that's consistent with bleeding. And if we look at the more distal portion, the more caudal portion, we really see separation of muscle fibers. If we really fully evaluate the intraaponeurotic space, more anechoic, hypoechoic fluid consistent with bleeding. So this is our diagnosis of a grade 3 medial gastrocnemius tear, perfectly demonstrated on this video clip on this dynamic scan. Here are static images of that patient. We put the Doppler flow over the musculature just to assess for any other differentials, neovascularity, that sort of thing. But this is also a great place to really pause and look at the pathology that we see. So hypoechoic fluid, bleeding, more hypoechoic fluid, heterogeneity in the muscle fibers. So medial gastrocnemius tear. If we remember from our history and physical, this patient actually presented 3 hours after his injury. So what was interesting when doing this scan is we actually began to see the hematoma evolve in front of us on the dynamic scans, and we couldn't really capture that in a dynamic scan, but over the totality of the whole scan, we saw that there was more progression. We're fortunate enough to have this patient present 3 weeks later for continuity of care, and we really began to see how that hematoma progressed, and it's really appreciable, the intraaponeurotic separation, the anechoic fluid, the bleeding that we could see here. But within this 3-hour presentation, our read for the final report for this structure is that there is a partial width, full thickness tear of the medial gastroc at the myotendinous junction with involvement of the gastroc soleus aponeuroses. There's an evolving hematoma. This is a left and right comparison at that 3-hour presentation, remembering that the left was the injured side and the right was the healthy side. So in the long axis view over here, we see that hematoma and anechoic fluid of the left, and on the right, we see that textbook image of nice homogeneous muscle fibers, no anechoic fluid separating the intraaponeurotic space. And then this is again corroborated in the short axis view, left side being injured, so heterogeneity of the muscle fibers, and on the right side, homogeneity of those muscle fibers, no infiltration, no bleeding. So this is a great image, really kind of driving that point home. This is an image from MSK room that kind of goes through the different grading system for medial gastroc tears. Strain is a grade 1, Grade 2 is a strain of partial rupture, and then a grade 3 is a complete rupture. And it goes through the different criteria of the fibroadipose septa, the aponeuroses, and the hematoma. But the thing that really clinched for us the grade 3 was the intraaponeurotic hematoma bleeding that we saw in those previous slides. This is the patient's lateral gastrocnemius on the left side. So nice, healthy tissue, homogeneous, nice space between, good abutment between the gastroc and the soleus, and we didn't see any bleeding or tear on that side. And these are just static images corroborating that homogeneous tissue, no bleeding suggestion. So
after we complete the ultrasonic scanning of the gastroc muscles, we move to the deeper muscles of the superficial posterior compartment, including the soleus and the plantaris muscle. The soleus is a wide, flat muscle that lays deep to the gastroc. It originates on the medial border of the tibia and the head of the fibula and inserts on the posterior surface of the calcaneus via the Achilles tendon. And the plantaris muscle is a long, thin muscle originating on the lateral supracondylar line of the femur, and in most people inserting on the posterior calcaneus via the Achilles tendon. Our ultrasonic evaluation begins in long axis over the proximal calf, and at this location you can see the muscle bellies of all 4 muscles of our superficial posterior compartment, including the lateral and medial gastrocs, plantaris, and soleus muscle deep. We switch to the long axis view and scan across the width of all this musculature, looking for any abnormality or disruption of the fibrous continuity. As we move more distally down the calf, you can see that we're no longer able to visualize the muscle belly of the plantaris muscle. The muscle bellies that we're visualizing here are the medial gastroc and soleus, and the tendon of the plantaris muscle can be seen both on short and long axis, lying in between the aponeurosis of the soleus and the gastrocnemius. As we move even farther distally, we can see the muscle bodies of the gastroc muscles begin to shrink and convert into tendon as we move into the more tendinous portion of these structures, and the soleus muscle really dominates our field of view. Within the soleus, we can see several hyperechoic lines that are represented by the lateral and medial aponeurosis and the central tendon. This picture here shows the course of these different structures through the soleus and can be visualized on ultrasound scanning. Here we present a frequent red herring, something that can be commonly confused for a medial gastroc tear. You can see this large hypoechoic defect in the area where the plantaris muscle usually sits, and this would be consistent with a plantaris rupture. For more information and a greater, deeper dive on plantaris tendon injuries, I'd refer you to the excellent lecture given by Dr. Weiss about 2 weeks ago on plantaris tendinopathies. Another differential we included was a bone stress injury, and this is what this can look like on ultrasound. Our images on the right show a normal longitudinal scan of the tibia. We can see smooth, hyperechoic bony surface without any defect. But when we look on the left image, we do see a disruption in that smooth hypoechoic surface. And you can see a thickening and a hypoechoic defect with reduced echogeneity below the affected bone surface. And this is consistent with a bone stress injury or periosteal reaction. To complete our posterior knee scan, we scan down the length of the posterior calf, visualizing the Achilles tendon. And here we're looking for any thickening, any disruption of the fibers, any surrounding fluid, or any bony changes. And in our patient, we did not see any evidence of discontinuity, and we continued the scanning down to the calcaneus and did not see any abnormalities with its insertion on the calcaneus.
Great. So that concludes our ultrasound scan. So now for the final report. The body of this was read to all of us as we went through the images. So for the sake of time, we felt that we'll just share the impression with everyone. So we saw a left partial width thickness tear of the medial gastroc at the myotendinous junction with an evolving hematoma dissecting proximally in the intraaponeurotic space. Number 2, the posterior knee was otherwise unremarkable. And number 3, there was no distal Achilles tendon tear. And that concludes our posterior knee evaluation. We just wanted to give a special thanks to Dr. Tony Bouffard, one of our musculoskeletal radiologists, and to Dr. Brandon Kakos, our program director, for assisting us with this lecture. And a general thank you to all of you, and thanks for listening and sharing this opportunity with us.
All right, guys, that was a fantastic presentation. Thank you so much for putting it together. I'll say, just starting off, I'll say you guys did a great job of like establishing a protocol and following that protocol and making sure that you covered all the high points and then adding in the extra things. And that's really, a big part of what this series is about is identifying a clinical scenario in which an ultrasound is indicated, and then identifying kind of a methodological way to proceed through a protocol of evaluating for your suspected diagnosis and then ruling out differential diagnoses. Just a couple of comments, and I'll open it up for any other comments or questions. I think, certainly whenever you're looking at like mid limb, so like calf, thigh, forearm, upper arm, it's pretty fair game to either choose the joint above or the joint below to look at. I tend to choose the ankle to look at when I'm looking at gastroc tears, and then I'll extend my scan up to look at the popliteal structures briefly and make sure that I'm not missing anything up there. But I think it's also reasonable to choose the joint above and then extend your window down below like you did to, make sure the gastrocs and Achilles and Soleus and things like that are appropriately imaged. As far as, the gastroc tear goes, you'd mentioned, that this is like a quote grade 3 tear. I think, one thing that I tend to look a little bit more at is there was a paper that a couple of years ago that was then turned into a blog post on BJSM on gastroc injuries by actually, I believe one of the authors of the book you referenced, Charles Pedret. And that was a really great infographic that looks at the different structures instead of, it's taking us similar to, what we did with what happened with the Achilles several years ago, where we said, oh, there was insertional and mid portion. And now we have several different varieties of insertional that maybe require different treatments. I think that we're starting to get there with muscle injuries. I know Ryan Cruz is doing a lot of work on trying to redefine, how we classify and evaluate those. I think the same thing can be said for these medial gastric tears. And personally, I find it really helpful to identify which anatomic structures are really injured. So is it the muscle? Is it the myoaponeurosis, or is it that free gastric aponeurosis, or is it multiple structures? And then on top of that, I put a lot of weight into if there's synchronous motion or dysynchronous motion between the gastroc and the soleus with active and plantar motion. And that's actually a big guide for me on when I start to return to strengthening activities, when that dysynchronous motion that can occur with the higher grade tears has resolved, is when I oftentimes start moving people forward. So like you got a re-imaging at 3 weeks, I'll frequently briefly re-image these patients, at intervals every, couple of weeks, or depending on how things are going, to see where we are from a healing standpoint. The other thing is, that can be really helpful with this is a lot of people that have really persistent hematomas tend to struggle. And so I'll frequently, if there is a hematoma that's amenable to aspiration and someone's a little bit slow, those kind of re-imaging can help kind of guide you towards draining that blood product out and allowing that scar to settle back in. Other than that, I think the other thing that you covered that I just want to re-emphasize is the differential in this area, including really those soleus injuries, especially kind of that distal soleus myotendinous injury, and plantaris injuries are frequently overlooked. And they can be really helpful to understand from a rehab standpoint. Should we be working on the gastroc, the soleus, both? And then, for the plantaris injuries, in those patients, especially in our athletes, we can really reassure them that they'll likely be able to return relatively quickly to sports because it's not a functional structure. Those were the comments I had. I don't know if anyone else has any thoughts. I see a couple of other consultants or attendings on the call.
Hey, Brendan, it's Ryan. So I'll just make a couple comments. So you guys hit the nail on the head with this, right? I mean, this is exactly what what we want from these presentations. And I'd probably say the fellows presentation has a new bar that's been set. So kudos to you guys. You did a really great job. I agree with everything that Brennan said. That paper, I put a link in the chat from the Spanish guys on classification system, a classification system for these gastroc injuries. It's a great paper with great images, and I tend to use that classification system. It's really helpful, like Brennan said, to really classify these as true muscle injuries, free gastroc aponeurosis injuries, and so on and so forth. So I would just take a look at that paper. I think it's really helpful. The protocols, your protocol was perfect. You did a great job with that. And kind of piggybacking off of what Brennan said, the protocols are critical and they're important, but they're not a substitute for clinical judgment. So you follow your protocol and then add in things that you find relevant based on your history and your physical exam and whatnot, which you guys did. So I think that's an important part or point to make here. The identification of the Plantaris is important here because that's going to sit right in that same tissue plane between the gastroc and soleus. And so sometimes these Plantaris ruptures, like you showed one example, can somewhat fool you into thinking you're seeing a gastroc tear. So just identifying that, which you guys did, I think was brilliant and was perfect. And then the only other comment I'll make, and again, Brennan did allude to this previously, but the timing of imaging of muscle injuries is critical. We get this all the time. It's actually gotten better, but we get it all the time where, somebody has a muscle injury and they want a diagnostic ultrasound 30 minutes later. And that can really bite you in the butt, to be honest with you. These things evolve, and you showed a great series of pictures. Your first image, certainly had some pathology there, but your follow-up, the hematoma was huge, right? So it was very obvious on your follow-up imaging. And so we think the ideal timing of these muscle scans is around 36, 72 hours post injury. Now, also, like you guys mentioned, and Brennan as well, if you're for whatever reason forced to see these a bit sooner, I have a really low threshold we'll scan them, but I'll bring them back in a couple days just to make sure I'm not missing something. Because again, you can get burned if you scan these too early. And then lastly, the point about doing follow-up scans, I think, is really important. There's definitely some literature looking at thigh muscle injuries and being able to identify whether or not these patients or athletes are ready to go back. We see all the time where athletes says, I feel great, I'm 100%, I'm rocking and rolling. And then they get back, and a month and a half later, they've got a recurrent injury. And I really do think that it's because that muscle is not ready to go, at least at the level these athletes want that muscle to go. So there's certain criteria that we'll look at. Brennan mentioned, whether or not contraction is kinetic or dyskinetic, looking for presence of ongoing hyperemia, and the hematoma that Brennan mentioned also. I think all of those are important. And once all of those are resolved, then at least in my mind, we can confidently say muscle has been healed and this athlete is ready to, to progress back to full activity. But I'm just reiterating points that y'all made. Like I said, you guys did an excellent job. So really kudos to you guys.
All right, fantastic. Thank you so much for your comments, Ryan. Does anyone else have any comments from the attendees here? All right, perfect.
There's a comment, Brennan, in the chat.
Yeah, that's a great question. So the comment in the chat is there a time where you would not aspirate anymore, if the blood is coagulated? That certainly is something that quite honestly we debate in our clinic on whether or not we should be aspirating these. Once, every now and then someone will sneak into our clinic who had an injury, 4 months ago or 2.5 months ago, and they weren't immobilized and they're still having a lot of pain, and there's a ton of swelling, and there's this big kind of wad of tissue / blood in that kind of interval between the gastroc and the soleus. And they can be really challenging because they can be multiloculated, coagulated. Honestly, if I see a fair amount of fluid and not a lot of just kind of scar tissue, what I will do is I'll use some lidocaine and some saline, and I'll try and lavage it and try and just loosen it up with a little bit of free fluid. And so I'll kind of, similar to how you would barbotage, a calcific tendon, I'll kind of quote unquote barbotage this coagulated blood, and I'll try and get as much of it out there as I can. Really what you want is you want these surfaces back in opposition so they can form kind of collagen bridges and try and start that healing process. And so I will sometimes, if people are really slow to respond or they're presenting really late and they have a lot of that kind of mixed hematoma picture, I will sometimes try and aspirate them. However, the success of that is, goes down as it gets to be a more complex fluid collection. If it's a simple fluid collection and I'm more than a couple of days out, so I think the bleeding has probably stopped at this point, I will aspirate them at that point. And then I will re-aspirate them if there's a large reaccumulation in a week. That's kind of my process. I don't know, Ryan, how you approach this.
Yeah, kind of the same thing. I think if you catch these in the first week, it's probably fairly simple fluid or simple blood product that you can pull out pretty easily. If I can't even get, mild compression with the transducer of that fluid, then I'm a little hesitant. And I also will go in like you, Brennan, and try and lavage these things. I don't know, they just haven't been as satisfying, to be honest with you. I think it's, for whatever reason, it's, like lavaging a fairly complex ganglion cyst, I think is a bit, at least for me, in my mind, a bit more satisfying and easier to really lavage and get that stuff out. But I'll try it with these chronic hematomas, but it certainly isn't as satisfying or as successful as other indications.
Yeah, certainly. That's a great question. All right. If there are no other questions or comments, we can end for today. Just as a reminder, everyone, will be back in a couple of weeks on February 10th. Dr. Joseph Chin is going to be presenting on ECU pathology and instability. And so we'll see you in a few weeks. Thanks again.